session topics today. We have closing gaps in care. And we have representatives from the University of Pittsburgh Medical Center serving as our panel in a way, who will be speaking with you about that particular topic today. Before I turn the tables over to them, let me just go ahead and introduce to you who the presenters are for this afternoon. We have to our far left, which is my far left, we have John Lovelace, who is president of UPMC for you. Welcome, John. We also have next to John, Annette Klein, who is also going to be serving as a presenter, and finally, Stephen Perkins. So we do thank you all for joining us here, and we'll hand the presentation over to you. Thanks.
Good, thank you very much. We have a couple-part presentation this afternoon. We're going to talk first about the structure of UPMC, just a little bit of background. We're going to talk about the integration of academic medicine, academic practice of medicine, and provider services, and the health plan as a three-way intersection of providing best practices in quality improvements. And then we're going to sort of finish up with a presentation on medical homes and how this is integrated into practice in real life. And at the end, if we have time, we have a case study, and if we don't have time, it's on the slides, so you can read that at your leisure. So we're going to start with the first slide and look a bit at just sort of the structure of UPMC. UPMC is a large integrated delivery and financing system based in Pittsburgh and covering largely Western Pennsylvania. We are a global health enterprise. We have about 20 hospitals in Western Pennsylvania, also hospitals overseas, cancer centers, a bunch of initiatives around healthcare innovations and business development. So globally speaking, we are about 55,000 employees, 3,400 physicians, about 9,000 nurses, a whole raft of other people, about 3,000 of whom work in the insurance division. As you can see from the slide, there are 4 divisions to UPMC. Each is headed by an executive VP. The hospital, they're pretty clear what they are. The hospital division is led by Elizabeth Concordia. It oversees all of the hospitals of UPMC in the service side. Physicians division is led by Stephen Shapiro. It includes both specialists and primary care doctors, as well as physician extenders, nurse practitioners, and physician assistants, basically the clinical and non-nursing staff. There's an insurance division. I'll come back to that in a minute. And then we have an international commerce division, which does most of the overseas work, including development of applications from science into commercial applications in healthcare. And then as you can see across the bottom, there's a series of enterprise-based services that support the whole organization around HR and financing and so forth that are integrated across all the major sectors. The insurance division has this little wheel of insurance. We like to think of this as being. It lays out a whole bunch of different business units, which I'm not going to bore you with, but in general, we are in the commercial space. We do about 400,000 commercial lives, some ASO, some fully insured, 120,000 Medicare Advantage members, of whom 15,000 are in a dual special needs plan for dual eligibles. We have a small chronic special needs plan for people with serious mental illness, and a small institutional plan for people who are institution eligible or institution resident. We have a Medicaid program, which is about 250,000 people, largely in Western and South Central PA. It is top-ranked medical quality plan for Medicaid in the state and number 8 in the country. We have over 25,000-person children's health insurance program. These are all separately organized lines of businesses, but integrated in a management sense. And about 700,000 people in a Medicaid behavioral health managed care organization, which operates largely in Pennsylvania with a bit of work in New York as well. In Pennsylvania, the Medicaid program is carved out at the state level into behavioral and physical health. So every Medicaid recipient has a physical health MCO, which they choose, and a behavioral health MCO, which also is at risk, which they are assigned to based on their residence. One of the challenges, of course, is for those to work together. Just you can see down the right side, just a couple of statistics about the program in general, and places where we're pleased with our work. The core of this work we do with the integration is focused in a group called the Aging Institute, which is a operating arm of the UPMC Community Provider Services, which is a subset of the hospital division. The Aging Institute has 3 major stakeholder partners who join in funding it. And those are, as you can see, the University of Pittsburgh, the Department of Medicine, and the Schools of Health Sciences, the health plan, UPMC Health Plan, and the University of Pittsburgh Medical Center Health System. So together we jointly fund the operations of the Aging Institute, which is a small organization. It's really meant to be the place where we centralize thinking about quality improvements, geriatric research, geriatric practitioners and training. UPMC is a large medical training facility. I think it's the second largest graduate training program for physicians in the country, with about 1,500 residents at any given time, and very large programs in geriatric care and palliative care and in end-of-life resources. The Aging Institute's role itself is to find ways to organize itself around the resources, looking at resources in the community tied to resources in the health system, as well as resources in academia and in the hospital system. So you can see that we're trying to build on what is known in research and try to apply that into real life. It's sort of the best case of transformational science into transformational practice. Just a little bit more on the Aging Institute itself. It has a board of about 15 people representing each of the schools of the health sciences, again, the health plan, the funders, the School of Public Health, the Dean's Office from the School of Medicine, the Vice Chancellor for Health Sciences, and a range of other stakeholders from the community and from academia. The focus is, again, to create innovative research and to find ways to apply that into practice. Some of the best practices in the Institute have been focused on quality improvement measures in geriatrics, including one of our new efforts, which is a very large CMS grant called RAVEN. Its focus is on, as it is in the health plan as well, reducing readmissions from skilled facilities to hospitals in 17 nursing homes, none of which are UPMCs. UPMC does own some nursing homes. 17 nursing homes which are independent in the community. It's sort of a teaching collaborative model. It's a network of geriatricians, administrators of nursing homes, Jewish Healthcare Foundations, a couple of local universities, again, identifying best practices, finding ways to implement them in practice. It builds on some work that UPMC had done earlier in its own nursing homes, reducing readmissions, unplanned readmissions by about 35% over 2 years by focusing on some techniques around being more observant, better training for medical assistant staff and certified nursing assistants, better alert systems, better attention to potential adverse drug events, and early warning systems. Key part of this in the nursing home is really an element called stop and watch, where nursing assistants who have the most contact with patients, of course, have a very structured program in which if something doesn't look right with a patient, they stop to look and make sure that things are okay. Someone doesn't eat their food the way they normally do. Doesn't mean someone has a temper, not sort of medical things, but really more things that are on this doesn't seem quite right, let's take a little closer look. These are often our early signs of a deterioration which one could reduce. Taking some of that knowledge and applying that to the RAVEN program will help extend this service, I think, and the quality improvement into a variety of nursing homes with different sets of incentives. Part of the mission of UPMC as an integrated delivery system, of course, is to align incentives so that we are providing the most efficient care in the most effective manner to as many people as possible. A couple other partnerships of the Aging Institute include the Palliative and Supportive Care Center. It's a large academic training program for individuals who are interested in palliative care and supportive care, particularly around end of life, but also around chronic disease management. It's a concept which is sometimes hard to integrate into the normal practice of acute care medicine, as people are, of course, trying to cure conditions. And sometimes that's not exactly the right thing to do. It's not really what the patient wants. It results from not really having the right conversation with patients and families. So this is we're trying to move the whole system, physicians, clinicians, with support of the financiers like the health plan, to really bring up conversations around what does someone really want to happen in their decision making around their continued care and their supports, rather than assuming we should do everything we can every time we have a chance to do that. The Disability Resource Center, we moved on the slide here. The Disability Resource Center is a UPMC initiative as well. It is focused on improving awareness and sensitivity to a variety of disabilities that patients of UPMC and staff may encounter in the course of their daily work. It was initiated a number of years ago after a sort of unfortunate incident of someone whose patient, who was admitted as an emergency patient, whose accommodations that he traveled with were not able to be accommodated in the hospital in which he was being treated. It was not bad intent by any means, but it did raise for awareness that we are not as sensitive to the issues of disability accommodations as we should be. Disability Resource Center focuses on bringing materials to bear, doing a lot of staff education and training, really around sensitivity and disability. So we aren't assuming people need or don't need something. It's a way of investigating it in a non-threatening and quality-based fashion. The Institute, again, engages to support research activities, and part of the research is a lab application which exists in the system and in the health plan as a funder. So we're going to move on and talk a little bit about a particular program, which you'll see in the case study at the end, excuse me, which looks at how we developed a falls prevention, osteoporosis management, quality improvement program based on what is known about endocrinology and orthopedics, what is known to work in research, and how that's applied in what we hope would be a better fashion in terms of improving quality scores and closing gaps in care for women over 65 with a long bone fracture. It's a great learning experience. Not every time we come out of the gate does it come out exactly as you might want it to come out, but it does move us along in a way of learning and being able to experience those episodes more productively. The major focuses this year have been on last couple of years in three areas, as you see here: dementia, caregiver supports, advancing treatment of dementia, incorporating dementia recognition and treatment into primary care, trying to be sure we have dementia supportive, dementia educated primary care doctors and staff who can help families with early signs and recognition and help patients to make appropriate adjustments to their conditions and supports. Falls prevention is a large scope, very heavy research base with the School of Public Health, with the osteoporosis management being a subset of falls prevention, because when falls are not prevented, there sometimes are fractures, and refracturing is the goal, to prevent refracturing. And then readmission rates. Readmission rates not only from skilled nursing facilities, but also from hospitals, any unplanned transition. It's hospitals to nursing facilities to hospitals, hospitals to home. The readmission rates are, as you know, across the country. Things we think could benefit from improvement. Aligning incentives differently, creating new tools, and creating new opportunities allow us to make some inroads in reducing those rates and improving the quality of care and in closing those gaps in care as well. There are four primary areas in which we have looked to do research in and moving from research to practice. One is improving the quality and the execution of home care. Home care is typically in many systems sort of a fragmented piece. As you move from hospital to home care, is sort of a cliff, one falls off and then resumes a course of action. More of a down to the canyon and back up to the other side than it is a bridge across the gap. So improving the rate at which people get timely home care in an efficient manner that is supportive of their needs and helps them to stay well and out of the hospital has been a very nicely researched opinion of progress with some good results in terms of reducing rates of readmission and improving rates of uptake for home care patients. And that's going to talk more about the patient-centered medical home. We've heard a bit from Steve in the last session, if you were here, about the work that we are doing in patient-centered medical homes. It's a very popular concept, as you can tell from listening to the Geisinger and Capital folks as well. Really a way of trying to bring a more robust approach to every patient. So people have a variety of needs and a variety of situations and a variety of resources, that we are not focused only on the condition that brought them in the door to the office, but also on needs that support those conditions over time. And we've talked a bit more about already falls prevention and osteoporosis management. Just a little more, a little more detail, and this is Annette's time, I think. So we'll move over to home care. I'm going to talk a bit about how we've moved in home care in real life, and then move on to patient-centered homes.
Great, thank you, John. I oversee medical. I'm a director of medical management and oversee several of the case management and special initiatives. One of the initiatives that we wanted to speak to you today about is what we're doing with home care and our Staying at Home program. We've collaborated with our UPMC Jefferson Home Care Agency in developing a program to keep older members at home as much as possible, to keep them at that level of care. Another initiative that you've heard a little bit about today is our patient-centered medical home, which includes several of geriatricians in our patient-centered medical home as well. We established our medical home in 2008, and we are currently in 178 practices to date, which accounts for about 535 physicians. We have practice-based case managers that they go from practice to practice. For some of our higher volume practices, some are assigned to one practice, but for our smaller, more rural practices, we do have them have multiple sites. One of the key components to the success of our patient-centered medical home has been engagement with the physicians. That's really been a key. Providing them with dashboards that are actionable and including quality metrics in in the reporting. We've also done a lot of collaboration with care plans, where we have case managers that work collaboratively with our physicians in developing care plans for our high cost and high frequent utilizers of care. We've all had these challenging patients that have complex medical conditions and a lot of behavioral issues. So we've really partnered with those physicians to try to develop care plans to impact and decrease utilization. And working with the physicians on the plan, so they're part of it, and it only really works with the physicians being involved. The health plan provides a lot of support for those physicians through the use of the practice-based case managers, through data and reporting that, again, is actionable and usable. We also utilize a lot of integration. We have something called our clinical data abstract, where the case managers can do research on specific members and really see real time what utilization they are utilizing and give that real time to the physicians. We can see when the members are filling their medications, if they're filling their medications, if they're going to a lot of different physicians outside of their PCP, if they're utilizing a lot of different specialists, emergency room physicians. It really gives the physician a wealth of information so they can understand what's going on with their patient. We also can support the physicians with pharmacists and doing comprehensive medication reviews, where we have a pharmacist that can do MTM reviews, comprehensive medication review, actually speak to the member, get underneath what could be occurring and what educational needs the member would have. And then also network management is also available to help the physicians and be a liaison when there's issues that occur within the practice. We already talked about how engagement is really a key in listening to the physicians and having them be part of the success. In selecting practice sites, that's been key. Obviously, we're going to select sites that have our highest volume of membership. But we also have other programs that we're going to speak of in a little bit that kind of wrap around the patients. So we have practice-based case managers, and then we have case managers that are embedded in hospitals where those physicians admit to. So there's a partnership where we have our practice-based case managers, and it's really a team with what we call our transition coordinators that are in the hospital side and manage the patient. And there's a lot of collaboration that goes back and forth. And then we also have, and we'll talk about this a little bit more, case managers that are embedded in high volume nursing homes that also, there's a lot of collaboration as well there. We have IT platforms that are crucial to the success of the case managers and management of the patient. We actually have some integration where we have discharge planning notes from the hospitals that interface into our system. And we also additionally have work that we've had with Epic, which is the outpatient record where our practice-based case managers document, and that information will be interfacing into our system where our case managers document. So it improves efficiencies, has the documentation in one place for everybody to see and be able to give better care. One of our big initiatives this past year has been our 5-day follow-up appointment. We have done a lot of analysis regarding readmissions and the link between follow-up appointments, PCP and specialists. And we feel that 5 days is the sweet spot in that patient getting to their PCP or specialist to prevent a readmission. So we've put a lot of resources and effort into trying to get these patients integrated into see their PCP within 5 days after discharge. Some of the strategies that we've used on this initiative is partnering with, on the hospital division, central scheduling, where they have open access to the physician scheduled if it's an owned UPMC practice. And they call the member the day after discharge and get those appointments made the day or two after discharge. We also have for our our UPMC affiliate or PCPs, we have clinical ops, which is frontline clerical people at the health plan that make follow-up appointments for those members. So again, a lot of time and effort put into that. We focus on top 10 diagnoses, and we also link admit reasons. So as you all probably are aware, you don't have necessarily the diagnosis real time. So we've linked admit reasons to the top 10 diagnoses that we want to really get these members in to see their PCP after discharge. And then we also have transition coordinators that are in the hospitals that one of their interventions is face-to-face getting that follow-up appointment coordinated as well. So we have several ways we're attacking the issue and getting these patients into see their physician post-discharge. So we engage members to close gaps in care and improve satisfaction. One of the strategies we're using, obviously, is to prep the patients before they reach to their PCP visit. We're working with them to come up with their questions for their physician so it can be the best PCP, the best follow-up visit it can be. So working with the members to empower them and get them prepared for their visit. Actually scheduling the appointments as we discussed earlier. Doing medication review, getting the patient to brown bag their medications and bring them in to the appointment with them. If you don't have the medications, you don't really know 100% what the patient's on. The only way to really know is have them brown bag and bring them in. So getting that conversation with the member prior to that visit and getting those meds rounded up before their visit is key. Again, using the clinical data abstract to see and get underneath what medications the patient really is filling. And also utilizing the health plan pharmacist to review the patient's medications before that appointment. So if there's any recommendations that need to be made with that PCP, that practice-based case manager can have that lined up with the physician before the visit. And really trying to improve member satisfaction, giving a real customer-focused attention to the patient, and having them outreach to us instead of it being us outreaching to them. We want them to feel like we're a value and get to the point where they are outreaching to us for assistance. Another program that has been live for a couple years now is our Optimal Discharge Planning Program. UPMC Health Plan was one of 6 selected sites in 2010 to be part of a AHRQ and Boston Medical Center study called Project Red, which stands for Re-Engineered Discharge. We picked one of our UPMC hospitals and health plan patients to collaborate. So patients that were admitted to one of our sites, we instituted this pilot. The pilot was successful, and we took lessons learned and modified the program to what we know today is our Optimal Discharge Planning Program. We've instituted Optimal Discharge Planning Program at 13 top volume sites where we have a large volume of our membership and where they're associated with a patient-centered medical home as well. There's 11 main components to Project Red. Some of them, to name a few, is follow-up appointment, education, care coordination, medication review. So we have these transition coordinators. They actually look at the patient's discharge post. Once the discharge orders are written and the nurse is given the discharge instructions to the patient, there are another set of eyes looking at the medications. They consult a pharmacist based on a certain protocol. If somebody's on a new medication of Coumadin, a new chronic medication, we have a protocol where we will involve a pharmacist to call the patient once they're at home as well. There is a lot of collaboration between the practice-based case manager and the transition coordinator. And also, there's a lot of collaboration with the CTT, care through transition nurse at the nursing homes with the transition coordinators as well. So really handing off the patient from level of care to level of care. Our skilled nursing facility program, where we call our care through transition program, our goal is to recognize problems early and deliver or facilitate appropriate interventions. We have case managers at some of our top volume skilled nursing facilities. We have nurse practitioners that work for the facilities on our behalf that do geriatric assessments of these patients as well. We do interdisciplinary team meetings on complex patients that need higher level discussion. And we have also something interesting that we've instituted at some of our sites called transitional care days. So patients that are in custodial care that are developing a condition such as pneumonia, UTI, they don't need the ED, they don't need skilled care, but they do need care to prevent them from becoming an ED visit or prevent them from being skilled. So what we'll do is we will reimburse the facility transition care days up to 3 days in an effort to prevent an ED visit, in an effort to prevent, the need for skilled care. So it's a nice program that we're starting to see some positive results. And this kind of looks at our whole paradigm of case management, where we have telephonic case managers, we have case managers, transition coordinators that are based in the facility. We have case managers based in skilled facilities and inpatient care. We also have community team. We have mobile case managers that can go out to the home and do visits in the home for those patients that we're having trouble engaging with, and focusing on members with severe mental illness that really need more complex case management. We have the practice. So we're really wrapping ourselves around the patients, and we do a lot of face-to-face case management. So we have our telephonic team, but telephonic can get you so far where sometimes you need that face-to-face engagement that is really more powerful. So we've really taken a lot of effort to have a lot of face-to-face member interaction. One other topic we wanted to discuss a little bit is falls prevention. Some of the work we wanted to mention with the University of Pittsburgh with Steve Elpert. He is involved with the CDC on funded work, looking at falls prevention, targeting high-risk seniors, looking at home-based assessments and preventative measures, and also seniors and family education, and hopefully trying to predict falls and having an impact on predicting falls and preventing falls ultimately. So more to come on that work as it's underway now. And then one of the last topics I wanted to discuss is our quality improvement initiatives with osteoporosis. So we've done a lot of work with, as I'm sure others have, with prevention in osteoporosis. We have the initiative is testing decreasing cost among our UPMC for Life members identified. Our interventions are decreasing injurious falls, achieving HEDIS stars for osteo management, and decreasing the rate of additional fractures. We have some mobile van interventions that we have done to try to get patients into their bone mineral density testing. And we have case managers assigned to aggressively work these members that have fractures to get them into their testing. And I think we're looking good on time.
You want to do a quick run through the case study, perhaps? Or maybe Steve would like to pick up on that?
One of the items that we can deal with, because we have finished, is how we're looking at healthy aging and bone health. and the work group that we have. And again, as John had mentioned earlier, this is a multidisciplinary approach with several different stakeholders. What you'll notice is we have what's called a, I think that, hold on just a moment, I apologize. This initiative has, is looking at, improving the testing and decreasing the rate of subsequent issues that may occur, whether it would be falls, linking them to home health services, linking them to providing assessments within the home, making certain that families understand issues that may be arising, or caregivers. It's, pardon me?
You're going the wrong way.
I'm going the wrong way. I apologize. I didn't think that that was right. I apologize.
This is why we have nurses.
That's right. The problem, as we've indicated, is about 50% of women have an osteoporotic fracture after the age of 50. A lot of these are hip and radial fractures due to osteoporosis. So what we're trying to do is deal with the issues that you see there with regarding the number of fractures annually, the hip fractures requiring subsequent treatment, and the cost and the mortality rate, which are extremely high in this population, and trying to identify them early. We have approximately in the health plan 1,500 members within our Medicare Advantage population, UPMC for Life, that experience fractures throughout the year. About 18% were related to the hip and the upper knee area. Excuse me, the femur, the long bone of the leg, the femur, and the knee, and about 6% were hip and pelvis-related fractures. In the past, our HEDIS measures have not been met for these particular conditions, and we were looking at this. Osteoporosis management rate was only about 27%, as you can see here. And we have areas where the management and the evaluation is very high, and we have other areas where it's extremely low. And it's trying to get that consistency throughout the population. Sometimes it's the engagement of the member, engagement of the family, as Annette had mentioned, with some of the mobile units that we have to assess, is there a significant osteoporotic problem that we need to identify through the testing initially. And what we looked at is these individuals who, as I mentioned before with regards to individuals over the age of 67 with the osteoporotic management, the bone mineral density test and or prescription for treatment or prevention of osteoporosis or an osteoporotic fracture. And how could we manage this, and how could we pull together the appropriate individuals to really affect this issue? So what we were trying to look at was to provide optimal post-fracture care, improve the HEDIS measures, and decrease the cost of the health plan. And the costs were not only in monetary cost, but in complications, in member satisfaction, in really improving that health of the member long term as much as was possible. Also making the member as active as was possible, depending on their overall condition. So trying to develop a solution to this, this is where we came up with the interdisciplinary work group that included the health plan and the University of Pittsburgh. We provided an overall needs assessment, looked at the priority of this population. We looked at our entire population of members, looked at it from a geographic standpoint, practice involvement standpoint, looked at it from particular areas where we could also involve community leaders. We developed osteoporosis management plan with the stakeholders involved, and then we evaluated this plan incorporating what we had placed into the process, any impact we'd have, and what our outcome objectives should be. The program, the individuals were identified by members age 67 and older. We initially had a case manager who involved the primary care physician early on, and the orthopedic surgeon early on to make certain that we had buy-in from the physicians, because as we found in a number of our programs, when we engage the physician community, we're able to get much higher engagement of the member. In addition to that, then the case manager ensures that services of a follow-up occur after that, whether it's home health, whether it's services through our EMAD program, which are through our emergency medical technicians, through home assessments, or through full physical therapy services, be it physical therapy, evaluation of the home itself, or evaluation of the status of the member with regards to their ambulation. The case manager would also ensure that the member, that the family, that the caregivers all had education with regards to fall prevention, with regards to osteoporosis, and with regards to treatment and care of the condition. For the members who agreed to the home visit, we were looking to assess fall prevention, their mobility. We worked with the PCP. We scheduled follow-up exams. We scheduled DEXA scans. High-risk patients that were identified through this program received multiple follow-ups. And the key component was the communication between the primary care physician and the patient throughout this endeavor. The patient education was essential, and making certain that we continued to provide ongoing information to that individual patient, as that was necessary not only for the patient but for the caregiver also. Three other areas where we're looking at quality improvement initiatives was under the readmissions work group, where we're participating in development with with some non-clinical skilled nursing staff to prevent the readmissions. I think that John mentioned a little bit about this earlier. A palliative work group that's a multidisciplinary work group that's working to train our skilled nursing facilities on completing advanced directives so that that revolving door in and out of the skilled nursing facility doesn't occur, and that we truly do know the patient and the family's wishes with regards to ongoing care. And finally, a triggers work group that's working to identify specific triggers to identify members that are necessary, where there's necessary end-of-life discussions and the need for advanced directives. We're doing that with our palliative care providers, with our oncologists, with a number of our subspecialist groups to make sure that we can identify these individuals not only on an outpatient basis, but if they do happen to be admitted. And if there are any further questions or comments, we did include our contact information at the end of the presentation.
I have a question, actually. I have a two-part question. I wonder if Annette or either of you could talk a bit about the qualities of a successful practice-based care manager. What kind of person, mostly they're all nurses, I think. What kind of nurses are the people who are best at doing this? Because they're not really the physician's office staff, and they're not exactly health plan care managers. It's sort of a hybrid circumstance. And part two of the question is, you can warm up here while I'm thinking about this. Part two is, certainly not in our experience, some physicians in the beginning particularly find this sort of intrusive, that don't meddle with my business, I know what I'm doing, leave me alone. And many of those people mostly turn out to come around and see this as a useful tool, not an annoying one. And I'm sort of wondering if you could speak a bit to how that transition happens.
We took kind of a three-pronged approach when we were looking to select and embed practice-based care managers in the practices. One was to very early on realize that these were not hospital-based nurses and hospital-based case managers in most cases. The second issue was we tried to set these up so that they knew their community, because there needed to be a lot of interaction with community resources, and so we were trying to find someone that would fit well. We're trying to have someone travel 50 miles to try to embed themselves into the community. And thirdly, we got although they were a health plan employee, we were looking for individuals who would work well with the individual physician practices. And so that there was a very close collaboration with the practices themselves in hiring these individuals to make certain that it was a good fit for the practice. Because we did have, as John mentioned, that obtrusive concern of the health plan being somewhat obtrusive, placing these practice-based care managers into the practices. But what we found is, as we engaged the practices and they realized the extra information and the enhancement that we could bring to the practice with regards to the programs we had set up, the data we could provide them, and the additional interaction outside of those 15 or 20 or 30-minute office visits, that it took a long, involved, drawn-out time. But right now, if I tried to remove one of these practice-based care managers from the practice that they're in, I would have a very difficult time, because they truly are now a member of a team approach within the patient-centered medical homes and within the primary care practices.
And one other comment would be, a case manager can make or break a program. It has to be somebody with really good communication skills, and that can, interact well with physicians, but not only physicians, with patients. So it does take a special person and one with the right skill set. So picking that person is critical to the success, and I'd say communication skills is also critical.
I think this sort of points to one of the key elements of this is a recognition that sustaining people, helping people sustain themselves when they have chronic medical conditions is certainly, first of all, a medical issue, but it's also a community support, family resource issue. That a person with difficult complex diabetes could be well supported with lots of people helping them and helping them pay attention, or very much on the edge of an emergency at all times, having much more to do with the supports they have and the services they get than it has to do with the condition itself. And I wonder if you could speak maybe for 30 seconds to how a care manager helps in that process.
Yes, and I think, the most common thing that our care managers find, and now our physicians are starting to understand this also, particularly the ones that now have these embedded practice-based care managers, is that very little of the issues that arise are related to the medical care that are being provided to them. It usually has to do with the environmental factors that are surrounding the patient, the socioeconomic factors that are surrounding our member or the patient, and the primary care physicians and our specialists are becoming much more aware that really is an issue. And if we don't address that, it doesn't matter what type of care they provide, we have to relieve some of the barriers that are occurring.
Additionally, the case manager needs to know when to bring in other resources. There's a whole team back at the health plan that's there to support, including social workers, pharmacists, and so on. So it's important for the case manager to identify when they need to pull in those additional resources, or even send a community team case manager out to the home to actually see what's going on.
I think we're about at the end of our hour. So again, if there are afterwards questions you can submit questions to CMS, of course, or you're welcome to contact us directly as well at any of the addresses up there. And back to our hostess.
Thank you very much. Thank you, Annette Klein. Thank you, John Lovelace, and thank you, Dr. Perkins. Very, very wonderful session here that we truly enjoyed. We appreciate your time in speaking with us today. Everyone, at this present time, we're going to go ahead and take a 15-minute break. We are on schedule. We do have one final closing panel discussion we do hope you come back and join us for. It's proved to be very exciting as well. So let's go ahead and take a 15-minute break. In addition to that, those who are actually dialing into that wonderful number we provided to you earlier this afternoon, we encourage you to also please be mindful that we're getting some background noise in addition to that as well. So if you could please also make certain that you are on mute, that would be greatly appreciated. Thank you, everyone. We'll be back at 3:15.